Good morning. It's 9:30 a.m. by my time, so I shall start this class. This is a takeoff from the last gross anatomy class I took on the arterial supply of the heart. In between, you have also had classes on the venous drainage and on the nervous conduction system of the heart. So you know its gross anatomy, its chambers. That is what today's class is about, the clinical connect. Now, there's not much that you can understand at this stage without learning all of the pathology of the tissues which make up the heart. But enough is known to be able to understand why we choose to address the problem in the way we do. In general, the philosophy in medicine and in surgery is to replace or reinvent or restructure the faulty organ, the diseased organ, back as close to its anatomical, natural, God-given structure as possible. And those same principles are followed. So for that, the anatomical basis has to be thoroughly known before a surgeon can attempt to restructure things which have gone wrong. So let's just proceed with this and get a sense of it, get a familiarity with the terminology, because these are applied anatomy questions which will definitely come up in your exams and which are definitely the basis of what you will learn in hospital from next term. So ischemic heart disease. Ischemia means lack of perfusion or lack of blood supply to any particular target tissue or organ. The problem there is not that blood is not reaching it, but that oxygen and nutrition is not reaching it. And many of our very specialized tissues are very vulnerable to lack of blood supply even for very short periods of time. So ischemia is a big deal, particularly for your vital organs like the heart itself, like the brain, like the kidneys. So we will see that some organs are better equipped to deal with ischemia for a longer period of time. Even if there is an acute shortage, they are able to cope. But many organs are not, and your vital organs among them are very important. So the heart itself has to be kept alive because it is a pump which works for you from before birth up to death without a stop. And that very hard-working myocardium is very vulnerable to even very brief periods of ischemia. So what is the anatomical basis of IHD, that is ischemic heart disease? Just a quick recap. In the last class we saw this was an anterior view of the heart, and we saw that there was a sulcus in which ran the right coronary artery, that's one, and it was accompanied by a vein. There was a marginal branch of the right coronary artery. There was a small cardiac vein. There were tributaries which were venous and branches which were arterial, which were more or less paralleling each other, but they were named differently. And then this right artery went over the edge, over the border, and went onto the posterior surface where it gave its very important posterior interventricular branch or descending branch. Similarly, there was a left coronary artery here which gave a left anterior descending branch, actually anatomically called the anterior interventricular artery, and continued as the circumflex branch. Here it is accompanied, here the vein is anterior interventricular branch. The vein accompanying that is the great cardiac vein. We've seen that in the vein class. So actually it's a larger caliber vessel, more visible, more obvious when you look at a dissection, when you look at an opened up heart, open the pericardium, and you'll see the venous vessels are more prominent, they're darker colored and wider bore. The arterial vessels are less prominent, they are lighter colored, somewhat reddish purple, but when you touch them, it has the arterial feel to it because there is more tunica media in its wall. But the point here I'm trying to revise for you is that both kinds of vessels are exactly in the same place. They look exactly the same, so it's the texture and to some extent the caliber which will tell you which is which. They are named differently. The veins are called cardiac and the arteries are called coronary. But this is the anterior surface and these are the branches that you see. You also see the conus branches coming onto the conus, that is the infundibulum of the right ventricle. Then you see the remaining wall branches which are called the right marginal, and there was a left marginal. From here there would have been a left marginal artery, not seen in this picture, probably this one. And these are again important vessels. We need to revise them before we get to what is ischemic heart disease. So in this picture I have more or less named everything that we have here. If you do a back view, if you see exactly the base of the heart, you'll see that most of it is made up of this left atrium and right atrium. Both of these are the atria with the big 6 veins entering them. And you see that in the coronary sulcus you have the coronary sinus, which is a big venous structure, the biggest of the cardiac veins, with tributaries going into it. And you see that the circumflex has come behind and given this downcoming branch, which is called the posterior interventricular or descending artery, accompanied here by the middle cardiac vein. So middle cardiac vein is on the back side, and posterior interventricular artery or descending artery, PDA, posterior descending artery, is on the back of the heart. And this if you look at it, if you're looking at a heart from behind, then right is right and left is left. So this must be branches of the left which are coming in, the circumflex which is coming and seems to form a continuum with the right. This happens very often that you can't see two separate vessels, but many other times you can see this one ending somewhere here and this branch coming only from the right side. This is the dominant, most common prevalence within the entire population of subjects, including you and me. But there are important variations which we saw in the last class, which we will revise here and see how it shows up clinically. So we saw this in the last class. This is only an anterior view again, as if the heart is transparent and you're looking only at its arteries. This is diagrammatic, of course, and you're seeing that the right coronary system is entirely in pink, the left coronary system is in red, and between the two of them they're forming that corona shape, the crown shape, which envelopes the whole heart. If you can see the ghosted line, the right coronary is going behind, and this posterior branch of it in this picture is giving the posterior descending. So then we call it a right dominance, if you remember. And so this one is not contributing to the interventricular septum or groove at the back, but it is taking care of the left marginal, it is taking care of the left anterior descending, and this circumflex is going behind and giving us little branch and stopping them. It's not proceeding any further in the major supply of the posterior interventricular septum or of the posterior walls of both the ventricles, which are being taken care of the right coronary. So a quick read through of the branches. We had a sinuatrial nodal artery, if you remember. This was ... and it went all the way here, and this is where the SA node was, and this was a branch of right coronary. Then you have the right conus artery, it was there in the previous picture. Right anterior ventricular arteries, 2, 3, 4, several branches, which are supplying this ventricle, which is the right ventricle on the anterior surface of the heart. And from the back, we had an AV nodal artery, because the right coronary is giving the posterior descending branch. At that same point, it is giving, where are we? It is giving the beginning of this light pink artery, which is the AV nodal artery. So right coronary is taking care of both the nodes as well as the posterior interventricular branch. Whereas on the left, we have a main stem, a short main stem, which we don't see because it's behind the pulmonary trunk. And once it emerges from behind there, immediately we see it seems to be giving a left obtuse or marginal artery. One more name for it is obtuse artery, and continuing as the circumflex branch behind. Whereas the main branch in the front is the anterior interventricular or anterior descending artery. This one is an oblique branch or a diagonal artery. So the name could be diagonal artery. So this word diagonal is given only for this in-between branch, whereas the one which is going along the left margin of the heart is called the left marginal artery. In this case, also called the left obtuse artery. The interventricular anterior septal branches, these are all branches from the interventricular main trunk, small ones you can see, and they will be given on the other side also. Same thing, this one, whatever is giving branches on this side, on the back, it will also give branches to the wall of the ventricle before it gives into the interventricular groove. So I think we've covered all the branches as they are named as a revision. If you were to take out the heart and dissect it, this would be the anterior surface. So if you're looking at right coronary artery like this, that means you're looking at the right margin of the heart. You're looking at the right margin of the heart. So you have turned it and you're looking at it from above, so that you're looking at the aorta and its exit, you're looking at the pulmonary trunk and its exit, just the beginnings of the two big vessels, and in between you're seeing that some branches have been given off. So right coronary main trunk is like this. This therefore becomes the right marginal artery, and here it is going over the edge. From here is given the sinoatrial nodal artery. This is basically a view or a dissection preparation with the vessels painted in red to show you the exact branches of the right coronary system and to show you how they start and how they proceed. So the course will be going in. This is the left auricle which has been pulled out with an instrument to show you that in the groove this artery is proceeding backward and around close to the, this should be SVC, superior vena cava, close to the superior vena cava, sinoatrial-nodal artery. So the superolateral or right view is to show you particularly this one branch of the right coronary, which is the common way that it is given off. If you look at it in this view, we see that from this aortic sinus, anterior one, is coming the right coronary, and here from the posterior aortic sinus or the left aortic sinus is coming the left coronary artery, which is going off into this gap between left auricle and pulmonary trunk. Don't see it here, and its branches will be on that side, just to show you where it is when you look at it in this particular view. So the point here was to identify the sinoatrial nodal branches. So if you look at it in a diagram like we saw before, this one's branch should have started somewhere here. This black line is the edge of the right auricle, and the branch would have gone into this groove and gone somewhere behind and around like that and supplied. But the variation now is that left coronary, which is the opposite side, where it has given off its left marginal branch as well as its anterior interventricular branch, that's the same place where it is given off a extra artery, which we are now going to call the sinoatrial nodal artery, because its target organ is going behind the great vessels, going behind the superior vena cava actually, and arriving at the same target of your sinoatrial node. So this is that small percentage of variation, I think 20% if I remember right, from the last class. I hope you have read up and come, because otherwise you won't make sense of what I'm saying today. So we have the origin, a variation or a variable origin of the sinoatrial artery from the left coronary system, not the right coronary system. But this is still not the criteria by which we say dominance. Dominance is for the which of the two arteries gives the posterior interventricular branch. So let's look at that. Just to show you again a dissection of how the sinoatrial nodal artery can come from left coronary system. So what we've done here, we're looking now at we looked at the right margin first. Now we're looking at the left margin of the heart, and we turned it in such a way that we're looking at the origin of the left coronary artery, and then we see that it's given off a left anterior descending branch, and it's given off its circumflex artery branch. And from circumflex it seems to be a new artery is emerging, which we are calling the sinoatrial nodal artery, because if you trace it backward, it will go on to the right side and end up at the sinoatrial node. So this is a dissected preparation. I'm calling it a preparation because we've cleaned it up and painted it also. So it's not just a dissection. And we are looking at it from a left lateral view. This of course would, though it's not named, must be the left marginal branch, because it's exactly along the left margin of the heart. So a variable origin of the sinoatrial nodal artery. Another thing which can happen with left coronary artery, this is the origin of the left coronary, big branch. We've moved the aorta out of the way so that it doesn't interfere with your view, and you're looking at it from the origin of the ascending aorta, from the aortic sinus, and it seems to have 1, 2, 3, 4, 5 branches, so we call it a pentafurcation, right? That's rare, we don't, it's in fact very rare. But to be able to see it, you need again a superolateral left view of the dissection. We didn't paint the artery here, but we are able to see that it is given off a conus artery, which anyway gives off normally. Then it gives off a left anterior descending, which is also normal. Then it gives off a left marginal, that's also expected. It gives off a circumflex, that's also expected, but not together from one single point. Usually it only divides into two, and then the conus is a branch of left anterior descending, not from the main trunk or the stem of the left coronary artery. So this was the fourth, and then the fifth is the sinuatrial nodal artery, like we saw in the last picture. So this kind of thing, trifurcation, quadrifurcation, pentafurcation can happen. They are rare anomalies. We can't even call them anomalies because they are variations which work very well. They may be found out only incidentally. Here in this person, we got it from a cadaveric dissection. It probably served the patient well throughout his or her life without causing any problem. As long as it doesn't cause any problem, it doesn't matter which kind of variation, as long as it perfuses the entire 100% of the cardiac muscle. That is the main thing. How it shares the territory between the left and right is not very significant unless a pathology happens, at which point of time you need to know what the pattern is before you try to fix it as a medical professional. Therefore, we need to know all possible variables, and a cardiologist or an interventional cardiologist or a cardiothoracic surgeon needs to know in minute detail how much percentage of the population we can expect this, and even minor variations of the sub-branches of these bigger vessels, bigger named vessels. Now let's come to the point of dominance, because that's important to know from the view of, because there are lots of studies on whether right dominant people have more heart attacks or left dominant people have more heart attacks. There's a huge amount of literature of the last 2-3 decades. The jury is still out. I don't think they've come to any typical findings, but to a surgeon who's going to attempt rectifying mistakes, all these little variations are very, very important, particularly if it doesn't show up as a block or it is not diagnosable in an angiographic study, but rather shows up as an arrhythmia or a dysrhythmia, in which case these finer branches, how much of the septum is supplied by whom, makes a lot of difference and will make a difference to the intervention, to the therapeutic, the corrective intervention that they plan to make. So in right dominance, just to recap, this again a posterior view. So this is left atrium, this is right atrium, and this is the right coronary main branch going into the back groove, the interventricular groove, and you have the right coronary artery giving the posterior interventricular descending arteries. You must remember we are calling it descending because if you put it in anatomical position and just flip it backwards, then it is descending. But here what we've done is you tilted it upward to be able to get this particular view of the base of the heart. I'll show you one more picture where it looks descending. It's going downwards towards the apex. So we are saying here it's looking sideways, but it's actually descending downwards towards the apex of the heart. So this is the descending branch, the posterior interventricular descending artery branch. If you call this main one, you can call any one of these the main one, and these are its branches. Whereas the left one didn't participate. It didn't even come to this point, which is called the crux of the heart, which is between left atrium, right atrium, left ventricle and right ventricle. So that point of the crux, this artery has not even arrived there. It has taken care of the atrial territory, to some extent the ventricular territory, but is not coming up to the interventricular septum yet. So this is a right dominant type of coronary circulation. This is the left dominant one, where the right artery has not come, it has come just up to the crux, but it is not participating in supply of much of either right ventricle. Instead, the left one is taking care of the whole left ventricle, the interventricular septum, as well as good amount of the right ventricular muscle. So then we call this a left dominant pattern of coronary circulation. So the same muscle, the same territories, but the way the branches have spread out on the surface of the myocardium, epicardium, and then their branches have penetrated into to supply all the 3 layers of epi, myo and endocardium. That is the pattern which we are looking at, which can be done in live studies in a live patient with a procedure called angiography. So we'll come to that in a bit. This is another picture just to show you the descending is descending. We've taken a slightly different view of the heart, where the coronary sinus is slightly more horizontal. In the previous picture it was more oblique, just to show you that the normal arterial pattern, the circumflex branch is coming here, giving the posterior left ventricular branch and continuing to anastomose with its partner from the right coronary, and you have the posterior interventricular branch coming from the right coronary artery at the crux of the heart. Whereas here the circumflex has come all the way and it has given an acute or rather almost right angle turn to give the posterior interventricular branch. This one has not even reached. This coasted one is the front root or course of the heart. The clear red one is the view that you are looking at from this angle. So the posterior interventricular branch, left dominance is 15%, right dominance is 85%. So this one is the minor way. If there are 100 of us in the class, 15 of us will have this and 85 of us will have the normal arterial pattern, which is the posterior interventricular coming from the right coronary artery. Remember this, and remember that when we look at angiographs, you have to be able to interpret, because there are no labelings in the x-rays. You have to remember the tree from anatomical dissection and then interpret what you're seeing in the live angiogram. So left dominance, you have the main stem, you have the circumflex, you have the circumflex going behind, going all the way across. See, it's crossing almost 2/3 the back of the sulcus, then terminating by making an acute turn and giving the posterior interventricular branch. In between, it's also given, they've labeled this as posterior interventricular. You label it according to which one enters the groove. At this point, I can't see the groove, but it seems to be continuing further, and this continuing further will anastomose with the ending of the right coronary artery. But this branch will therefore, now if this is interventricular, then this much is left ventricle, beyond this is right ventricle. So these two, 1, 2, 3, so many branches are also taking care of the supply of the right ventricle, more than an inch from the interventricular groove to 1 or 2 inches. So a good majority of right ventricle from the posterior side is being supplied by the left coronary artery. So plus it has dense branches to the anterior surface and the left margin. The right coronary comparatively is taking care of less territory, but it has given its sinuatrial nodal artery, it has given its conus branches, and on the anterior surface it seems to be taking care of the entire right ventricle, even the marginal artery, almost the entire right ventricle. Because this is the anterior interventricular groove, which is taken off by the anterior interventricular branch of the left coronary. So the point is that left coronary is giving the major descending branch from the front as well as a major descending branch from the back. Therefore, it is the left dominant, both anterior descending and posterior descending from left coronary arteries. This is again another way of looking at it. To remember also, there are veins in the same groove, but when you do an angiogram, you are injecting the dye exactly into the arterial system, into branches of the ascending aorta. So they do not fill up the venous system. To fill up a venous system, the dye which you have injected has to perfuse through the arteries, then get deoxygenated by the myocardium. Then that has to enter into the venous system and come back into the great, middle and small cardiac veins. But by the time the dye gets much diluted and you won't get to see it. So you don't get to see a venogram. We never do a venogram. But we can do venous studies by getting into the chambers of the heart and retrograde introducing a catheter into the coronary sinus, which is lying in the sulcus. But that never needs to be done usually. Sometimes we need to do it at least to see if there is any variation in the coronary sinus itself, because you might be wanting to follow it to locate the nodes, because the anatomical location of the nodes is closely related to the coronary sinus. We will look at that when we actually open up the heart and show it to you in practicals. For the time being, just remember that there are veins accompanying. It's just a recap of what you've done in the previous classes, where the arteries originate, where they branch, and the two major areas of anastomosis. One at the back between main right coronary and main ending of circumflex, and two between the descending branch of right coronary and the end of the left anterior descending branch. These are two major areas of anastomosis between the left and right coronary arterial systems. A so-called balanced supply has a very rich anastomosis between the two sides and maybe a joint branch. That means this anastomosis at the back is so thick and so patent, blood is flowing well from both sides. So actually the posterior descending branch gets blood from both sides. There's sufficient blood pressure on both sides, so it is filling the posterior interventricular branch. You can't actually say that the posterior interventricular is a branch of only left side or only right side. That's called a so-called balanced supply. So that also is possible. So the interarterial anastomosis assure that there is a continued blood supply despite partial occlusion of individual vessels. Now suppose there was a little bit of occlusion here. This blood would flow through the anastomosis, cross and come into this, and therefore into its branches, whatever branches it may have given off here. That is the point of a surface anastomosis if it is of good caliber, good lumen, and is sufficient to fill up the branches beyond the block. This is not very common, but it can happen. It's very good for your patient if that is the way they are supplied. In one sense, it is the only downside is that because perfusion is taking place, the patient doesn't come to you with any symptoms. So you will not put them through any investigation. So you won't discover that there is a block somewhere because the perfusion is being, or the lack of perfusion is being compensated by the very good anastomosis available. Alright, so let's go to this. Now let's come to the clinical anatomy. So you know from your general reading and from your whatever little general knowledge you have from before that angina pectoris is a common presentation. You'll be seeing them in a few months' time in the hospital. So angina means pain and pectoris means chest. So chest pain occurs when this coronary circulation is reduced for any reason. So it could be that the artery has undergone a spasm. It is constricted. The lumen has been narrowed. The tunica media is squeezing for some reason. Very often it is due to emotional, mental stress. Smoking is a very well-known cause of angina pectoris due to vasoconstriction. It could be due to blockage in the vessel. It is after all a tube in which a liquid is being transported from one place to another. It is traveling from a high pressure situation to a low pressure situation down the branches of the arterial tree. Now this blockage could be due to a thrombus. Thrombus is basically a blood clot which has developed there, or an embolus, which is a block probably of a blood clot origin or with some other components which is formed somewhere else, but it has flown down the flow in the artery, that means down the river, and it has come into the branches and it will come and get stuck somewhere where the vessel is narrow and the embolus is too big to transit through the vessel. So that's another way. It's also probably a clot, but it has not formed here. It has formed somewhere else and arrived here. Plaque, on the other hand, is not a blood clotting mechanism, but rather a vessel wall pathological change mechanism where only the cholesterol derived components within the blood have been deposited because of a very high concentration. They've been deposited in certain areas on the very smooth endocardium, or rather the endothelium of the blood vessels, tunica intima of the blood vessel, slowly, small quantities over a long period of time, till the fact that it is stuck on the inside of the tube reduces the lumen of the tube sufficiently so that not enough blood is passing into the distal segment, which is when the chest pain will occur. So any of these three pathological mechanisms can give rise to this symptom called angina pectoris, and all these three are blocking the vessel. So that is one way that the difficulty can happen. Another rarer one, but sometimes easiest, fastest to pick up as far as your patient symptoms are concerned, is just simply a reduced blood flow to the heart without a typical diagnosable vasoconstriction and no blockage. This is almost physiological. You can say excess. For example, physical exercise, bodily exercise after consuming a large meal. Most of the blood, if you remember, after a meal, all the blood will go off to the digestive system, right? And that is by the parasympathetic overdrive, the rest and digest overdrive. The blood will be shunted into the gastrointestinal system so that more of juices will be provided, more peristalsis will happen, and the blood can absorb all the nutrition which is brought into the GIT. Therefore, since you have only a finite amount of blood, it will get reduced in all the other circulatory fields. So the brain, the heart, the kidneys, everybody will get less blood or less normal blood, least normal blood, which is available. Sometimes at that point, if you exercise, if you do muscular contractions, there is a demand, there is an oxygen starvation, there's an oxygen demand from the muscles, and blood will need to be pushed. There will be a mismatch between where the blood would normally have flowed and where the demand has happened. And obviously when there's exercise, cardiac muscle is going to be really a high area of demand for oxygen, and it will be pumping harder, and therefore there will be a mismatch between the oxygen demand and the oxygen supply, because myocardial vasculature will get less blood now since it is immediately after a wheel. Because of that insufficiency, angina pectoris can happen, not because of vasoconstriction happened, not because there's a block. So this is rarer. So very often it's very important to ask a history of why that chest pain happened. We spend a good amount of time trying to get the patient to share with us how exactly the pain was brought about, because then only we'll get a good idea of whether it's more or less a physiological thing or it is actually a pathology which we need to investigate further and find out what exactly happened. So if it's pathological, it could be because of a spasm. This is temporary, though in this diagram it's looking like a permanent narrowing. Spasm is by its own name, by its definition, it is a temporary narrowing, and it will relax. Not easy to pick up unless you take an electrocardiogram or an angiogram exactly at that point where the spasm is occurring. But an atherosclerosis, where you can see there is a development, a laying down of plaque within the vessel, or an atherosclerosis with a blood clot overriding it. That is usually the commonest way that the angina pectoris happens. Atherosclerosis, please remember this is not arteriosclerosis, which is another word. Remember the spelling and write it down correctly. So in a normal artery, you have a uniform lumen or bore of the vessel, of the tube, and you have a smooth blood flow with a smooth tunica intima of the artery. These are all medium-sized arteries, right? If you remember your histology, there were 4 types of vessels. So coronary arteries would come under medium-sized arteries. And the artery narrowed by atherosclerosis, you have this plaque laid down on either side. So this was the inner lining. This was the inner lining, and between the inner lining and the myocardium, a bunch of material has been laid down. Now, in a longitudinal cut section, you're seeing it on the left and right, but it's actually laid down all around. Therefore, the wide lumen of the vessel has been narrowed, and then again widened out. So this is only for this segment that you have a narrowing, and when the blood is passing through this, it is not sufficient. The distal portion will be less filled. It won't be so much filled as much as it should, but it will be less filled, slower over a period of time, and the target area, the receiving area, will be starved after a period of time. So how this works is that you have all these RBCs, WBCs crowding the lumen. All of this is the content of the blood. This is the tunica intima. This has got disturbed. It has been wounded, you can say. It has been, the fibers have frayed out, and underneath that this material has been laid down, which is mainly fatty deposits derived from your cholesterol. Plus, because there's a tear, macrophages will rush into these areas and they will form what are called foam cells, and this tear will allow platelets to also flow in there and start trying to heal this wound, the tear in the wall, and a clot will develop over and above the plaque. But that is a later pathology. Earlier pathology is that plaque is first being laid down. It will get thicker and thicker and tear through. This is the myocardial cells, and this is the epicardium. So don't look at this. The point is to show you that right adjacent to the lumen, just deep to the tunica intima, material is being laid down. So when you look at it, the normal blood flow is like that. When material has been laid down, it reduces the lumen and narrows the flow, restricts the blood flow, because the plaque is taking up space in the circumference of the arterial wall. So this is what it looks like at the atherosclerotic coronary artery. If you look at it in TS, if you do a cut section, you see that a thrombus has formed over and above these fatty deposits. So fatty deposit in the wall and a thrombus is not very clear. So one way is a narrowing. So you have a spasm, that is a reason. The blood flow is reduced in the distal segment. This is what the cut section will look like. Then you have a narrowing because of the plaque formation, the atherosclerosis. then you have a blood clot forming on top of the plaque. So you have a plaque which has already reduced the lumen and a blood clot blocking off whatever remaining lumen is left. So you have a full block. Though the size of the vessel is normal, it hasn't, you're not seeing a spasm or a narrowing, but the entire lumen has been blocked off by this double pathology of a atherosclerosis and a blood clot forming on top of it. If it is just a plaque, this is how it will look like in TS, a very narrow lumen, a full circumference plaque, and the wall. In this one, you have the wall, you have a plaque, and you have a blood clot. The radiolucence of these tissues is slightly different. When you look at it in an angiogram, only experts are able to better decipher it, but at least you will be able to make out when it is blocked and when it is not at this stage. So what we have seen is different causes: a spasm, a plaque, and a plaque with a clot. Usually it's a plaque with a clot. Sometimes there is no plaque, the entire lumen is blocked only with a clot. That's usually when the embolus has arrived from somewhere else. So this is called an arteriogram. Graphy or gram is the, or graph is the picture you get, the picture that you actually get to see, the physical evidence of it. Graphy is the process of arriving at that picture. Thallium is the radio-opaque dye which is used in these procedures. Next stage after angina pectoris, where there is only a brief sudden acute pain and it relaxes. So the patient is very uncomfortable but has come back to almost normal and comes to you usually in the interval. By the time they arrive at you to you, the angina is over and they are almost normal, and you may or may not be able to pick it up in an ECG or any investigation. Whereas a myocardial infarction is that the insufficiency has lasted long enough for a piece of myocardium to actually die, to actually be irreparably damaged. That's when you call it an infarction. So an insufficiency, that is myocardial ischemia, may result in MI. So it's like saying a harder, more pathologic or more morbid stage of the same process. So the sudden occlusion of a major artery, the region supplied by the myocardium becomes infarcted. That means it becomes almost bloodless for a period of time and therefore undergoes necrosis. That means tissue death will happen. This is essentially an acute deprivation of oxygen. The heart loses some of its contractility. You must remember, you've done the conducting system. The whole heart works like a singular muscle, though the different chambers have different loops of muscle and they contract at different times with very essential small gaps between atrial contraction and ventricular contraction and relaxation and valve movement. So it's exquisitely coordinated to do it in a particular pattern, which is absolutely important to life. So if any one little bit of muscle dies, the myocardial contractile continuum, that the syncytial nature of cardiac muscle, it's not syncytial but rather cardiac branching of myocytes we saw in histology. The continuity of the impulse to contract is lost because one small few thousand muscle fibers are dead and cannot pass on the contractile rhythm. Therefore, it can lead to a dysrhythmia. So very often the outcome of this infarction is a dysrhythmia, or the entire heart, reflexly the myocardial muscle reduces its contraction or almost stops, in which case we call it an arrest, but otherwise it fails to completely empty the blood from the heart into the outgoing vessels, which is basically the aorta. And that failure will result in the aorta not filling up with sufficient cardiac output and therefore not being able to perfuse the entire body. And that's called cardiac failure. So all of these are outcomes of just this pathological tissue death because of the infarction process. So losing some of your contractility can result to dysrhythmia or heart failure or cardiac arrest. We are not talking about human death. We are talking only about the heart going into its own pathologies, which we will study in detail next year. But you must know the terminology and why it has happened. So when myocytes die, the active tissue, the remaining tissue, which is alive and well, becomes the active tissue which was there, which has now died, becomes replaced by scar tissue, and the remaining heart tissue tries to overcome this and tries to overcome the loss of this much tissue with certain reactions. That will be seen in the disease called myocardial infarction when we see it in a patient. So this is just a small little bit of introduction of what exactly happens. So what do we do in a coronary angiograph? We take a catheter, a small tube with a metallic needle to begin with. We introduce it into the arterial system and we thread it up retrograde into the arterial system, which means into branches of the aorta, because we are targeting the beginning of the ascending aorta, which is where the coronary arteries start. So we put the catheter inserted into a blood vessel in the groin, very commonly the femoral artery. You all have done lower limb, you remember where the femoral artery is. So we cut down into it, we put the catheter, we manipulate it up the iliac, external iliac, common iliac, descending aorta, and into the beginning of the ascending aorta. And there, when we enter, so we have threaded it up here, and we've gone up here, the black line, and we've come to the beginning of the ascending aorta. So you have the coronary sinus, beginnings of the right and left coronary arteries. Then you thread it into the artery which you want, right coronary in this case, and you inject the dye into the angio. So the angio is the blood vessel, this one, and the graphy is you want to take a picture of it. So the tip of the catheter is pushed inside the right coronary artery and the dye fills it up, and wherever there is a narrowing because of an atheroma, that is your atherosclerotic plaque, it will show in the X-ray picture. And the catheter, wherever there may be, so there may be one block or there may be two blocks or there may be multiple blocks, whatever it may be, will show up. Similarly, you pull it back and push it into the left coronary, and you fill up its arterial tree. If it has a block, it will show up there. This is the principle and the procedure by which you do it. The whole procedure is called an angiography, right? The common areas where this gets blocked is one. This is the left anterior descending vessel, branch of left coronary. So it's a common area is one. Two is the beginning, the main stem of the right artery. 3 is in the circumflex branch of the left. 4 is the main stem of the left coronary. 5 is this is a posterior interventricular branch from a right coronary. This is a common place for it to get blocked. And 6 is in the main continuation after giving of the marginal branch, the continuation of the right coronary. So this, you remember the branches, I won't repeat them. These are the common 5 to 6 areas where we frequently see angiography showing us narrowings or blocks. So in a coronary, for the right coronary for example, you see this is the right coronary. So this would have been the right ventricular branch, another right ventricular branch, posterior left ventricular artery, posterior descending artery. From here the sinusoidal nodal arteries given. Can you see, you can't see the heart muscle at all, you only see the tree, the corona, and you have to be able to interpret which part you are seeing and which one you are looking at, right? So you see that this is the posterior left ventricular stump. You're seeing the posterior descending as if the heart is transparent. It's not ghosted. You're seeing the whole thing filling because it is filled up with the dye. In this particular picture, nothing seems to be narrowed. All the branches seems to be doing well. Whereas in this picture, we've taken from the left coronary artery. Now this view is a little difficult for you to understand. If this one is the main stem and this is the left anterior descending, this is the interventricular septum, that means interventricular groove, right? So left circumflex is behind it, but you can't see which one is anterior, which one is posterior, because the entire heart is not filled up. The dye is only filling the vessels, so you don't know how deep this vessel is, whether it's on you, towards you or away from you. But you, with a little practice, you'll see that this is the left circumflex artery and it's filled up nicely till here. Beyond this point, it doesn't seem to have filled much. So there's a 99% stenosis here, but there is some amount of filling happening in the other vessel, in the distal vessel, which may be explained by anastomosis from the other side. We don't know that yet, but we are looking at, the cardiologist is looking at how much compensation is taking place and what is the extent of stenosis and what is the distance of stenosis. By that he will decide how much of a stent, which type of stent to choose, and so on and so on. So it's a very sophisticated and detailed expertise which is required to be able to figure out from this diagram itself what else to do. They will also do probably MRI studies and cardiac function studies, physiological studies, to figure out how much of the myocardium is viable and doing well, worth saving. Sorry to say, but very often the clinical decision is a trade-off between whether we are early enough to be able to save that muscle, or whether it's too late, there's not enough viable thing. Should we put the patient through a very debilitating surgical process if we are not able to get the recovery that we expect? So all of those decisions will come later, but the basis of that is first a coronary angiogram. Another thing we do is a magnetic resonance angiography. You see the pictures are also different. This is not done like the previous one, and the view is also different. The vessels are lighter, the background is darker. In the previous picture, the vessels were blackish, darkish, and the background was light grey. So basically this is a completely different pathology. This was ascending aorta, this was an arch of aorta and coming down, and somewhere in the arch there is a narrowing which is called a coaptation. So you're looking at branches of the aorta, and from here would have arisen all the coronary branches, which we are not looking at today. We're looking at the other branches, just to show you what a magnetic resonance angiography looks like. This can also be attempted for the heart. So in angioplasty, now let's come to the how do we manage. I have only a few minutes left. So the anatomical basis of how we attempt repair is all that we are going through. So the surgeon will pass a catheter just as he has passed for the angiography, but on top of it there will be an inflatable balloon, and when we bring it to the point of the constriction, we will inflate the balloon. Till here it will not be inflated, and when it's inflated, this plaque gets pushed against the vessel wall. So the balloon is inflated, flattening the atherosclerotic plaque. Then the vessel is stretched to increase the size of the lumen. So when the balloon is fully pushed, this narrow area is widened. Then we can also insert medications, in this case thrombokinase. This enzyme dissolves a blood clot if it is also present there. Usually because there's a narrowing, there will be a slowing of blood, the tendency to develop a blood clot. So it's like a negative spiral. There is a narrowing, clotting will tend to happen. Because of that, more narrowing, because of that, more clotting will tend to happen. The pathology is, it goes off into a spiral. So this whole thing, because we have gone via the skin into femoral artery and then gone up the tree, it's called percutaneous. That means you're doing the whole intervention through the skin. Balloon angioplasty. So you introduce the catheter with the balloon collapsed. You come to the block. At that point, you push through the block. Once it is in the center, you inflate the balloon, and then the plaque gets pushed. And then after you have removed the balloon, the lumen, the bore of the vessel has been restored to almost normal. The plaque is still there. You've done nothing for it. You haven't changed it in any way, but you have re-established the circulation. So the end point that you want is that you crush the blockage and re-establish the continuity. But you can also do an extra bit, which is what is commonly called the coronary stent placement, where you go in and on top of your catheter there is a wire mesh longitudinal cylinder which is collapsed here. Once you get in, you expand the wire mesh and it stays expanded, and you withdraw your catheter with the balloon. So the stent stays in place, continuously compressing the plaque, and it will give you a more long-term solution. Now we have medicated stents which slowly release. It's called elution. It slowly releases very small quantities of medication, which will keep that entire arterial system in keeping the flow continuous and reducing the possibility of future blockages or future clotting, both. So we have drug-eluting stents available nowadays. So when you see it in TS, you have a TS, the plaque was there, you put in the balloon catheter with the stent, and then you expand this, you widen that. So here you have the stent, big one, it has fully expanded, and the plaque has got compressed or crushed against the vessel wall, and this stent you leave it in place and you come out. Bypass graft. If stenting is not possibility for whatever reason, some patients will undergo a coronary bypass graft. A segment of an artery or a vein is connected from ascending aorta. So this is the right coronary and this was the left coronary. So you take another vessel. You take out a piece of vessel from somewhere, or you take a branch of another nearby vessel, and you connect it from ascending aorta or proximal part of coronary artery to the distal segment. So if the block was here, the blockage was here at this point, you take some vessel and stitch it from before the block to after the block. So you bypass the block. That is the purpose of a bypass graft. So in this particular diagram, two are shown. One is you take a internal mammary artery. This right internal mammary is a branch of the subclavian system. It's outside of the pericardium. But this internal mammary artery, as far as the heart is concerned, in the chest, while it is in the thorax, this artery is lying on the pericardium, is lying external to the pericardium of the heart. So when you open the pericardium, keeping this vessel intact, you take that outside vessel inside to the epicardium and you stitch it up to the beyond the block. So from here the blood will come and replace whatever is not being perfused beyond the block. You don't do anything to the block. That is called a bypass. Another thing you can do, this is a segment of a saphenous vein. It has been taken from your saphenous vein, which is your lower limb. The whole thing has been taken off, cut into an appropriate length section, and you do an anastomosis to arch of aorta, ascending aorta, and to beyond the block. The block is here, so before the block and beyond the block are connected by the bypass. So you can have a venous graft, you can have an arterial graft. There are several methods and methodologies available. The surgeon will choose what is most feasible for that particular patient. So this was basically showing the same thing. You've taken a graft from here to here, or you can take a graft from here to here. This is basically the opposite of the previous picture, where here you're taking from the left internal mammary and you are attaching to the left anterior descending beyond the block. So the stitches here, I just wanted to show you the stitches. So it's a very beautiful end to side anastomosis between one big artery and a smaller artery, and the same thing has happened here. The stitches where you are ending the graft. Now you might think, how can a vein help, right? You take a vein and attach it to an artery, and how will that happen? You must remember that the vessel is a tube. It's essentially a muscular tube, and the beauty of living tissue is it will adapt to the pressures under which it is coming. So when that segment of vein is going to receive arterial pressure blood, it will build up its tunica media, and within a few months' time it will be, you cannot distinguish it from a regular arterial structure. It originally was a saphenous vein because that was the function it was doing when it was in the lower limb. But now this tube is in the coronary circulation under the pressure of the cardiac output 120/80, and it will learn to take the pressure, and it will continue to give the blood supply to the much more vital organ here, which is the heart. So if you know the anatomical basis, we can adapt it. We can create ways to re-establish anatomical structures as well as possible to be able to save your patient's life and serve them. It has been known that triple bypasses have been done. So you've done one from here, taken it from ascending aorta because the block was here. Then there was another block here, so you took another graft and you put it up here. And then there was a third one in the circumflex, so you took another graft and you put it up here. So together it's called a triple coronary bypass, and it can be done in the same setting. But for this you'll have to open the pericardium and you'll have to shut down the heart for a bit. So it is a open heart surgery, and you have to shunt the blood through a external machine so that it keeps getting perfused while the surgeon is operating on the quieted heart. So that's a completely different, much more risky surgery. Nowadays bypasses are done much less because firstly we diagnose early, therefore we can get to it when the block is smaller and there's still good amount of cardiac tissue healthy left. Secondly, stent mechanisms and stent development invention has become very sophisticated, and a lot of times we can do a less traumatic intervention, only a percutaneous intervention, and get the same result without actually having to do a bypass. So this is the state of the art now, and by the time your generation comes into clinical medicine, maybe new things will happen. For the time being, please remember the anatomical basis of ischemic heart disease and the management of ischemic heart disease as it stands today. In the next class, we'll go back to histology. We'll come to small intestine. Please try to read up and come, and I'll see you in the next class on Saturday. Thank you.